Our next PowerPoint is multiple sclerosis, or MS. MS, what happens, and we'll go into this a little bit more in depth in a few slides, but basically your immune system is attacking the brain and the spinal cord, and there's a specific response I'll talk about coming up. It's a chronic neurologic disorder of the nerves of the CNS, and specifically how your immune system attacks the myelin sheath. The onset of MS is usually between the years of 20 and 50. Women are affected 2 to 3 times more than men. It can be more prevalent in those temperate climates, so extreme cold or extreme heat. The cause is relatively unknown. It could be related to a multitude of factors, including a genetic susceptibility. There are a multitude of other factors that are associated and could be considered precipitating factors, but it's controversial. This is going to include infection, smoking, physical injury, emotional stress, excessive fatigue, pregnancy, a poor state of health. But overall, there's going to be these 3 pathologic processes that characterize MS. The first one is going to be chronic inflammation. The second is demyelination, which is damage to the protective covering or myelin sheath that surround nerve fibers in the brain and spinal cord. When myelin sheath are damaged, nerve impulses are altered. The next part is gliosis in the CNS. The primary neuropathologic condition is an autoimmune process that's orchestrated by activated T cells, which we'll talk about on the next slide. So T cells are these immune response cells that divide quickly when they're activated, and they secrete cytokines, which are protein. So an increase in activated T cells migrate to the CNS in multiple sclerosis, causing a blood-brain disruption. This initial activation of the T cells is likely the event that develops MS initially. There is subsequent antigen-antibody reaction that leads to the demyelination. The onset of the disease is insidious and gradual. You could have vague symptoms occurring intermittently over months to years. So we'll look at this lady a little bit. She's a 35-year-old that presents to the clinic after experiencing generalized weakness and blurred vision. Whenever I think of MS, I always think of vision changes, and we'll talk about that more in depth. She complains of feeling an electric shock down her spine and chronic fatigue. She reports feeling this way for around a year, but it appears to be gradually getting worse. Her blood studies come back normal, but her MRI reveals small plaques throughout the brain. These small plaques are classic when you have someone that has multiple sclerosis. What possible triggers could be related to her MS? We kind of mentioned those already, but could be infection, could be trauma, pregnancy and delivery, stress, changing climate. Initially with MS, attacks cause damage to myelin sheaths of the neurons. The nerve fiber itself is not affected, so they can still try to send impulses, it's just not as efficient. Patient may complain of noticeable impairment of function. With ongoing inflammation, the myelin actually loses the ability to regenerate. And again, without the myelin, the nerve impulse transmission is disrupted. Common manifestations of MS include motor, sensory, cerebellar, and emotional problems. A lot of patients complain of numbness or weakness in their limbs, complete or partial vision loss, tingling and pain, electric shock sensations when they move their head, tremors, lack of coordination, unsteady gait, fatigue, dizziness. The symptoms tend to be intermittent, and the intermittent nature of the symptoms often are what dissuades the patient from seeking immediate medical attention. and therefore the disease may not be diagnosed until long after the onset of the first symptom. So, MS is characterized by chronic progressive deterioration in some go through remissions and exacerbations, but progressive deterioration in neurologic function is what occurs even if they have repeated exacerbations. There are four main types of MS. The most common one you'll hear of is the relapse remitting. There's also secondary progressive, progressive relapsing, and then there's primary progressive, and that one is super rare. The last one there. Since the disease process has a spotty distribution in the central nervous system, the clinical manifestations will vary with each patient according to the area of the CNS that's involved. Some patients will have severe, long-lasting symptoms early in the course of the disease. Others may only experience the occasional and mild symptom for years, even after initial onset. Motor manifestations, so the muscles are chronically affected. There could be weakness or paralysis, diplopia, scanning speech, which is very interesting. And usually I show a video about Selma Blair and how she exhibits scanning speech, and what happens is she speaks in syllables. If you go to YouTube and look up a video, you'll see what I'm talking about. And then there's spasticity of the muscles as well. Patients with MS experience a variety of sensory abnormalities. They can have numbness and tingling, blurred vision, STAR-that because vision changes, like I mentioned, are fairly common. They can have vertigo and tinnitus, decreased hearing, chronic neuropathic pain, and then Leigh-Hermity's sign. It's a transient sensory symptom described as an electric shock radiating down the spine or into the limbs when the neck is flexed. Some cerebellar manifestations are nystagmus, again, STAR-that, that's speaking to the eyes, ataxia, dysarthria, dysphagia, and then there's fatigue. Severe fatigue is present in many MS patients and causes significant disability for some of them. The fatigue is usually associated with increased energy needs, heat, humidity, deconditioning, depression, and medication side effect. Bowel and bladder functions can be impaired. Your spastic bladder is accompanied by urinary urgency and frequency that results in dribbling or incontinence. Generally, urinary retention occurs with a flaccid bladder. Another urinary problem is a combination of both of these. Urinary problems cannot be adequately diagnosed and treated unless urodynamic studies are completed. Sexual dysfunction can occur. That can be erectile dysfunction, decreased libido, difficulty with an orgasmic response, painful intercourse, and decreased lubrication. Some cognitive manifestations, they might have problems with their memory, so their short-term memory attention, their attention span, information processing, planning, visual perception, and word finding. And then the emotional response, definitely important. Anger, depression, euphoria. Physical and emotional trauma, fatigue, and infection can aggravate or trigger signs and symptoms as well. So what do you say to someone, think about these people in their 20s to 50s who has just been given a diagnosis of MS for which there is no cure? I think you should give them some time to internalize this, but definitely you would want to explain to them that although there's no cure, we can help with your symptoms. We can help you to go into like a remission. There is no definitive diagnostic test for MS, meaning like you can't draw a blood level for MS. But there are a bunch of ways that we can figure out if the person has MS, or to figure out if they don't. So it's based primarily on history, manifestations, and the result of a multiple or a multitude of diagnostic testing. The MRI of the brain and spinal cord could show the presence of plaques or lesions, inflammation, atrophy, and tissue breakdown and destruction. These plaques or lesions can be as small as 3 to 4 millimeters. The CSF analysis can show an increase in IgG. And then the next one there, the presence of oligoclonal banding, which is bands of immunoglobulins, that's key. Usually there's 2 or more bands in about 95% of MS patients. So they have found that when you see this oligoclonal banding in the CSF, you're thinking, okay, this could potentially be MS. We also look at evoked potential studies to look at nerve conduction in the eye and the ear. Overall, how do we actually say, okay, yes, this is MS? The person has to have evidence of at least 2 inflammatory demyelinating lesions in at least 2 different locations within the CNS. So what's the CNS? That's your brain and that's your spinal cord. The damage or an attack has to occur at different times, usually about a month apart, and all other possible diagnoses need to be ruled out. This shows is demyelination plaque at the P location, at gray white junction, and adjacent partially remyelinated shadow plaque, which is what V is showing. These plaques are found throughout the white matter of the CNS. Again, there is no cure for MS, but our care is aimed at treating the disease process and providing symptomatic relief. Therapy is tailored specifically to the disease pattern and manifestations that your patient is experiencing. So, drug therapy that's used to slow the progression of MS is going to include immunosuppressive therapy. An example of a drug that can be used is methotrexate. There's immunomodulators. Immunomodulators, they're regulatory, they adjust, they modify the disease progression, and they prevent relapses. One of the most common that you'll see is going to be interferon beta. Interferon beta, it's given subcutaneously every other day. It does have some nasty side effects, such as depression and suicidal ideation. It also causes photosensitivity, and you have to teach to rotate injection sites. The next one there is guatiramer acetate, or Copaxone. I don't see that one as common. Definitely interferon beta first, but can also be used. And then the adrenocorticotropic hormone can be utilized. Some more drug therapy. There's Gilena that reduces disease activity by preventing lymphocytes from reaching the CNS and causing the damage. For more active and aggressive forms, they can use IV natalizumab, and that would be IV monoclonal antibody therapy. There's also IV methoxytrone, and that's IV chemotherapy. And then there's dimethylfumarate, which is an immunomodulator that's used for more aggressive forms of MS. And then again, we see the use of corticosteroids with our neuro patients very frequently. We also see it with our multiple sclerosis patients. So a couple examples are listed there. Those are helpful in treating exacerbations by reducing edema and acute inflammation at the site of demyelination. Now think about corticosteroids with these patients, though. There are side effects. There's an increased risk of infection, hyperglycemia, GI bleeding, etc. Many different side effects. And then there is the use of other drug therapy. I would focus more so on immunomodulators, immunosuppressive therapy, and corticosteroid therapy in general for people who have MS. The next drug, it's a newer therapy. It's acrelazumab, and this drug, it's very useful for patients that have remitting MS, which is that most common form. But the good thing about this drug is that it's been shown to have or has been shown to improve um, the disease in patients that have primary progressive MS. So it's the first drug that has actually been utilized to treat patients with primary progressive MS. It's given by a nurse who is specifically trained to give these drugs. This drug is considered a monoclonal antibody drug. It's an infusion. It's given every 6 months. Um, Before the patient has the drug, they have to have a corticosteroid administered and a antihistamine. This reduces the infusion reaction risk. They also have to have Hep B screening done. If they have hepatitis B, they cannot receive the drug. Lastly, on there is that stem cell treatment. Basically, that's going to help reboot the immune system. We delve more into stem cell transplantation when we talk about our hematology unit, though. Other treatment, it could be done to help with spasticity of the muscles. Surgery can be done. Dorsal column electrical stimulation, which helps with the spasms, can be implanted. And then some of these patients actually have intrathecal baclofen pumps, so they're constantly getting baclofen into the intrathecal space. Neurologic dysfunction sometimes can improve with physical therapy, also with like speech therapy. Exercise improves daily functioning for patients with MS who are not experiencing an exacerbation. Assessment wise, we should look at some subjective data. So, do they have any history of viral infections or vaccinations? Do they reside in those temperate climates? Any extreme physical or emotional distress? What medications are they on? Any weight loss, dysphagia, or elimination problems? Health history wise, we want to know if they have any muscle weakness or fatigue, tingling or numbness, muscle spasms. The next one are your eyes and ears, so any blurred or vision loss, diplopia, vertigo, or tinnitus. Do they have decreased libido or impotence? And then any of those extreme emotions, anger, depression, euphoria, isolation. And then here we want to know, do they have, when we're assessing them objectively, do they exhibit apathy, which is a lack of interest or inattentiveness? Any pressure ulcers? Scanning speech, which is that broken word or spoken word that's broken up into syllables. Basically, they pause between those syllables. Do they have any tremors or nystagmus? Ataxia, which is a lack of voluntary movement of the muscles. Spasticity of the muscles. Do they have hyperreflexia, decreased hearing, muscle weakness? Paresis, which is muscle weakness caused by nerve damage. Paralysis. Do they drag their foot? Do they have slurred speech or dysarthria? What are some of the possible problems that LS may develop as the disease progresses? And how can you help anticipate to adjust these problems? She could start to experience fatigue, neuro changes, constipation, bladder changes, things like that. And then I would assist her through the grieving process. She's losing the ability to do a lot of things, so you need to be there for her, listen to her. Common complications in your MS patient will be muscle stiffness or spasm, paralysis, which is often in the leg, problems with the bladder, bowel, or sexual function, mental status changes or memory, which include memory loss or problems concentrating, depression, seizures, and then add to this list that women who are pregnant, they may have worse symptoms during and after pregnancy. That's possibly due to the hormonal changes that occur during and right after pregnancy. So, our nursing diagnoses, we can have impaired physical mobility, impaired urinary elimination, ineffective self health management. Planning wise, we want to do things that maximize their neuromuscular function. We want them to maintain independence with their ADLs as much as we can, manage any disabling fatigue, optimize psychosocial well being, help them adjust to the illness, help them decrease factors that precipitate their exacerbations. Of course, we want to help the patient identify triggers and develop ways to avoid them or minimize their effects. You should reassure the patient during the diagnostic phase, assist them in dealing with anxiety and grief caused by the diagnosis. During exacerbation, the patient may be immobile or confined to the bed. The focus of nursing intervention at this phase is to prevent major complications of immobility, such as pressure ulcers, respiratory issues, or UTIs. Focus teaching on building general resistance to illness, so avoiding fatigue, exposure to cold climates, exposure to people who are sick, people who have infections. And then if they have an infection, they need to recognize it early and treat it vigorously. Patients should know about their treatment regimen, drug side effects, how to watch for and manage side effects, and drug interactions with any kind of OTC medications they take. Bladder control is a major problem with your patient with MS. So you may need to teach the patient or others how to do catheterization. Bowel problems, possibly constipation, occur frequently, so they need to increase their dietary fiber intake. And then think of other interventions that'll help the patient um, if they have issues with constipation. The patient and the caregiver may need to make many emotional adjustments because of the unpredictability of the disease, the need to change lifestyles, and the challenge of avoiding or decreasing precipitating factors. So, we want to be able to hook them up with any kind of services that will help support them. Overall, our expected outcome is that our patient will maintain or improve muscle strength and mobility, use assistive devices appropriately for ambulation and mobility, maintain urinary continence, and make decisions about their lifestyle modifications to manage multiple sclerosis. The answer to this question is C. Um, because they don't have to worry about that. They do need to rotate injection sites. They do need to report any depression or SI. And because they're photosensitive, it's important that they use sunscreen and avoid direct sunlight.